Hi there. My name is Krista McKeechuk, and I am going to be sharing my research and the study that I did regarding deaf seniors' access to healthcare settings, ASL interpreters' perceptions. This research was done over the course of almost 2 years now, not including the previous years that I was in the classes. So I'm graduating about 2 years later than I would have, but I'm very excited to finally be at this point. So I'm going to just walk everyone through my slides, and I hope that you enjoy what I have to share. All right, let's go. The point at which I decided what I wanted to research was when I was taking a course called Deaf Culture and Community, where we talked a lot about the groups within deaf communities that are minorities. So minorities of already people that are minoritized. Um, so when I learned more about deaf senior citizens and the challenges that they faced in everyday life, I kind of thought that this might be a really good choice to research and investigate a little bit further when it came to them accessing medical care, medical treatment, just medical attention. And so that's how it all began. The relevance of this study is obviously important to why I proceeded with it. According to Lesh 2019, within the United States, there are about 2 million deaf people. Among those 2 million people, 60% are over the age of 65. Any of those individuals who identify as part of the deaf community and use ASL as their primary language are likely to encounter barriers to comprehensive healthcare and therefore are at a greater risk to caring for their own health and well-being. Interpreters are a key component in providing communication access for deaf people with their healthcare providers if the deaf consumers prefer communicating via American Sign Language. So that's a little bit more about the relevance of my study. This research investigates what sign language interpreters can do to help mitigate the barriers that deaf seniors encounter in medical settings. That is my research statement. That is, in a way, my research question. I want to know, what can interpreters do to help mitigate barriers? So I think I've done a pretty good job at answering that question. Initially, I had a scenario in my head where a severely arthritic deaf senior had an appointment with her primary doctor. This is just something I thought of. And I wondered what the interpreter would do in that circumstance if communication was not happening due to the physical limitations of the deaf person's hands or arms due to the arthritis. I wondered how a physician's appointment slots would likely not be long enough to accommodate all that there is to cover, seeing as how communication could potentially take much longer. This thought process snowballed into thinking about a ton of other challenges a senior person might face in various medical environments. I'll walk you through my lit review, my methodology, the analysis, the discussion, and the conclusion. So to start off with the literature review, I focused a lot on Steinberg, 2006, providing a lot of wonderful pieces of information that connected well with my research. The American with Disabilities Act upholds that all healthcare providers and facilities are mandated to provide reasonable accommodations, including communication access. Title IX of the Civil Rights Act of 1964 houses the law that says healthcare facilities and providers are to provide adequate language support to people with limited English proficiency. And my research was not focused on the implications of having no interpreter. Many of the articles that I found address consequences occurring when the interpreter is absent. So in a way, it was related, but in another way, I wanted to know more what was happening when deaf people had an interpreter present. Lazzoni, 2004. I cited a little bit more of this person's work with deaf and hard of hearing people's perceptions of healthcare. And there, as this quote says, there are conflicting perceptions of communication modalities. Deaf participants report frustration with physicians not requesting a sign language interpreter specifically trained to work in medical settings. And then, of course, as I mentioned, in regards to times of appointments, interviewees sought more time than clinicians could or would give. And that's a major barrier because the process of translating requires a little bit more time. And especially if you're not interpreting simultaneously, perhaps going into consecutive work makes the most sense in those scenarios. I have Lianza, 2005. Do interpreters help build bridges between these two symbolic worlds, physicians' perceptions of interpreters and interpreters' roles? Interpreters have various roles, and I think most would admit that. We don't just come into a room and robotically, mechanically do our jobs. This is a profession of working with people. And so we have to be more flexible because we are working with so many different consumers every single day. Lianza actually touched upon my research question. This person briefly introduces the different roles interpreters can take on. Some of those roles include translator, cultural informant, cultural broker or cultural mediator, advocate, bilingual professional, and translation machine. And Kuhnberg in 2016, this person's work touched on deaf minority groups such as women, ethnic minorities, and elderly deaf individuals might be at a particular risk for disparate healthcare treatment. Again, those minority groups that I already mentioned and the additional barriers that they may face. Barnett, 2002. I enjoyed reading this author's research. Barnett touched on healthcare workers and their ill preparedness to accommodate deaf and hard of hearing people. Some of the literature, in addition to Barnett, did discuss that topic. They either don't have interpreters, they did not know how to request an interpreter, or they thought writing notes back and forth, depending on family, to translate, or assuming lip reading was sufficient enough to make communication happen. In other cases, medical facilities only had the use of a VRI, but the use of that device presented its own problems, whether it be user error or technical issues or simply a poor fit for the patient. And a quote from this author is, "A lack of access to information results in deaf people having a limited fund of knowledge about many health-related topics." Holmes in 2018 had a piece of work that discusses ASL interpreters' perceptions of healthcare. And particularly a statement that this author had that sits closely to my research and curiosity was, even when interpreters are present, the use of teach-back methods, visual aids, and other tools are not commonly practiced. And I found this really interesting because even a hearing individual who's in a medical environment and they're trying to educate themselves more about what's going on with their own bodies and their own diagnosis would probably benefit from teachbacks and seeing diagrams and photos. But I don't know how often that actually happens. And I'm thinking to my own personal experience. But I am also a more health literate individual than maybe a deaf person or a deaf senior person. The quote continues to say, this affects the deaf and hard of hearing patients, their quality of care, and their ability to appropriately follow medical instructions following their appointments. Himmelstein in 2018 published a piece of work and that was mostly about healthcare workers are poorly prepared to partner with interpreters. Again, another fascinating occurrence. Mitigating barriers for deaf seniors should not just be one-sided, with the responsibility falling on the shoulders of the interpreter. The findings in Himmelstein's research point to the benefit of not only exposing and educating medical students on limited English proficiency patients and how to work with them, but to also reserve time within their formal educational programs to practice working with medical interpreters and LEP patients. I further wonder what outcomes would occur if new generations of medical providers had more formal training with interpreters and deaf patients. So my methodology was pretty simple. I recruited participants via the snowballing method. I sent out an email including the information you see here. Call for participants was emailed to a network of professional working interpreters in the Department of Access Services at Rochester Institute of Technology, and also to interpreters working at Strong Memorial Hospital in Rochester, New York. Dr. Robin Dean helped me by sending my calls for participants to her network of colleagues and coworkers and previous cohorts of the MS HCI program. And I really appreciate her doing that for me because it definitely helped gain the number of participants that I needed. I originally really wanted to host a focus group with the 7 interpreters that were willing to participate, but because of time constraints, we were not able to do that. My interviews were semi-structured, and I provided prompt questions to guide the discussion. I didn't necessarily limit the time, but naturally, in knowing how long a person would be willing to sit to answer questions because they're giving me their time, I kind of felt that maybe 60 minutes would be their max. And as the course of discussion occurred, naturally the conversations went no longer than 60 minutes. Coding information, again, here, it's pretty straightforward. I used content analysis, Microsoft Excel, and my categories were created in ways that they grouped together via common themes. And then part of that coding involved the main ways interpreters can reduce barriers and filtering and separating the information out that way. My participants, as I said, there were 7 interpreters. They're all still actively professionals out working. They worked in hospital settings and medical centers. Some stayed in just one location, others traveled from environment to environment. They had 5 years to 22 years of experience amongst all 7. Everyone was certified, and part of the way to be qualified for my study was that they had to have regular contact with deaf seniors. I don't necessarily know how I would define regular contact, but I would think that they can at least look back on experiences where they're interpreting for deaf senior citizens, you know, once every couple of weeks, if not more often. A thematic analysis was conducted of the data to identify overarching themes. And then a content analysis was also done to pull out any representative themes. So now we're on to the main themes that I decided to go with. So for this analysis, I am talking about barriers encountered by deaf seniors in medical environments. And I was able to cite several: facility and technology challenges, language challenges, and then cognitive challenges and comprehension. In terms of the discussion, I also go on to touch upon liberal controls versus consecutive, cognitive decline of older patients, and interpreters and their empathic understanding of deaf seniors' feelings. Interpreters can make choices when they're in their work, liberal controls, like the one that you can see in the previous slides, the first quote, can lead to interpreter leaning more in the advocate role. Other possible interpreter roles could be, but are not limited to cultural informant, ally, machine, and so on. Discovering how the interpreter perceives their role and how the physician sees the interpreter impacts the relationship between all three parties. A more consecutive control would be to wait for or ask a nurse to come into the patient's room and interpret the deaf patient's comment regarding wanting a live interpreter. Employing either one of these controls generally results in successful communication either way. As the second quote on the previous slide shows, there's interpreter empathy, and that comes with being, I think, a human being and trying to understand that deaf individuals' circumstances and their loneliness. And then the third quote in the previous slide is, I'm going to say that although I did not read any literature regarding cognitive decline of geriatric patients and the impact that this has on the patient-provider relationship, it is clear that the potential for mismatched communication will impact interpreter decision-making. Per the DC schema, interpreter choices will impact how the conversation will progress. And consecutive interpreting is likely a better choice. Code of professional conduct and its influence on interpreter decision-making. This was really interesting when I had participants talk to me about their views on the CPC. I was really surprised when most of them, although respecting the CPC and understanding why we have it as a group of people who are professionals, that it's not something that should restrict interpreters. It's not something that should impede their ability to do their job and do their jobs well. I love some of the quotes that I got from my participants. And just the simple one, it's not always about language in what we do. Sometimes it's about just human connection. And that is so true. This also speaks to patient-centeredness is critical. And we find ourselves in places where we're advocating for these consumers, for these deaf senior patients. I kind of already said what I have on this slide. The first quote on the previous page ties back to Schuler's publication in 2013 when she describes, if a patient who's deaf and hard of hearing becomes ill, injured, or dies as a result of poor communication by the healthcare professional, that professional is at risk for serious legal consequences. And I mean, all healthcare providers, and being well-intentioned, do not possess the knowledge of the various types of communication that deaf people use. Unfortunately, this leads to uninformed assumptions based on insufficient information. And to speak to the second and third quote, human connection, human-to-human situations, and patient-centeredness are all similar ways of saying that practicing medicine and interpreting medicine isn't just a black and white process with a mechanical approach. Providers, interpreters, and patients all have the same goal in mind: to get the patient well. Getting there may require more interpersonal skills from the physician and or the interpreter. The provider-patient relationship will be impacted by clear communication and developing that connection. Barnett, 2002, says, attitudes and statements that perpetuate the inaccurate belief that interpreter services are for the patient rather than for clear clinician-patient communication can be damaging to the clinician-patient relationship. Educating others about deafness, deaf culture, and what interpreters do. You'll again see the word advocacy here, and then role of the interpreter and empowering deaf people. There are a few quotes over there to the left from my participants. The last quote says, some of my older deaf patients don't always realize that they have the right to do that. This person was referring to this deaf senior citizen's right to tell the hospital staff to call for an interpreter if they needed one. Unfortunately, I did not come across in any of the literature I read comments about advocacy for deaf people. And clearly I didn't come across anything about advocacy on part of the interpreter. Had I been able to read more, I probably would have found information. The second quote speaks to the role of the interpreter being dynamic. Interpreters provide a service, but that service has to be tailored and modified to the consumer's needs. Holmes says, even when interpreters are present, they use, and I already mentioned this quote, I apologize, I already read this. It is difficult to tell who it is to blame when things aren't going well. And I don't like to use the word blame, but is it the physicians for not realizing they need to use more strategies and tools to explain complex concepts to their deaf patients, or interpreters for not letting them in on the critical component? If interpreters can see the CPC as their ethical compass, but also recognize the dynamic nature of their job, they may feel more comfortable suggesting to physicians that their consumer is not understanding, and the use of other materials to explain would be helpful. And then just to speak to the third quote from the previous page, in this quote, the interviewee describes a deaf individual did not seem to realize it was within their rights to tell the staff when they needed to have an interpreter. The interviewee said she informed the deaf person he did have the right to ask for an interpreter. This could be considered advising, which is in conflict with the RAD CPC, specifically Tenet 2.0, professionalism, 2.5, refrain from providing counsel, advice, or personal opinions. However, the Americans with Disabilities Act says that basically deaf people have the right to an interpreter, and if this is in theory supposed to be common knowledge, then the advising done by the interpreter is really cultural mediation, which is part of the role of the interpreter. Furthermore, Lazzoni, 2004, claims older persons who are hard of hearing can find note writing difficult because of low vision, arthritis, or fatigue. Additionally, the authors claim Under both laws, patients' preferences should receive primary consideration, but physicians or other providers determine what constitutes effective communication. Neither the Section 504 of the Rehabilitation Act of 1973 or the Americans with Disabilities Act of 1990 requires insurers to cover interpreter costs. Clinicians cannot charge patients for this expense. Interpreters have power. That is what I gathered from my interviews. Because we have this power and because we know we have this power, it must be used for good. It must be used to benefit the consumer. And that results in teamwork and partnership, trust, and responsibility. If you feel like you want to take another few seconds to read those quotes, go ahead. This is further interpreter power themed information. We also have privilege. We also can provide education. Advocacy again comes up, and obviously no one is invested in this process to do harm. Everyone's goal is to do good. So there's a lot to say about those two previous slides. I'm going to try to keep it quick. Interpreters are the only people in the exam room that know both hearing culture and deaf culture and how to mediate between them. When the interpreter arrives, there should be an immediate sense that all parties can trust that professional with the task of making communication happen. A quote from a participant was, taking liberties, taking responsibility, providing cultural mediation. We are the conduit, right? We are the medium. And so if the communication in any way doesn't seem to be effective, then I think we just make other decisions. Someone who is a strong supporter of the CPC and only following the CPC is not going beyond what it says we should. That person might say, oh, well, telling the physician to slow down and repeat isn't something you should do. Or talking with the nurse in the hallway about why this patient is here is not professional. Talking about them with someone else, talking about their needs, isn't professional. According to Steinberg 2006, participants preferred working with medically experienced interpreters or with healthcare practitioners with sign language skills. This is consistent with the findings of McKinney et al., who found that deaf adults seeking care at a clinic with easy access to interpreter services reported higher satisfaction with healthcare communication and were more adherent with some preventive health recommendations than deaf adults who sought care elsewhere. Although the publication did not say, beyond the fact that medical interpreters had specialized training, why healthcare experienced interpreters were preferred, it might be assumed that, along with their specialized training, these professionals may also use interpersonal skills, advocacy, rapport building, cultural mediation, etc., to benefit all the parties involved so everyone can have a desired outcome. This is a reflection of interpreter power. Furthermore, there are strategies I identified through the analysis where participants highlighted things they do physically and things they do with the language to help mitigate barriers. Some of those things are physical placement strategies, using consecutive interpreting rather than simultaneous, building rapport, and again, we see teamwork and partnership. So I'm going to talk just a little bit about that. Deaf people's perceptions of healthcare. Lazzoni 2004 says, there are conflicting perceptions of communication modalities. For example, deaf participants report frustration with physicians not getting a sign language interpreter specifically trained in medical sign language. Okay. And in regards to time of appointments, interviewees sought more time than clinicians could or would give. Additionally, hard of hearing respondents reported that physicians would not speak more slowly even to facilitate communication. And I believe that this was mentioned earlier in the presentation, but it just highlights that this is an issue. Interpreters are constantly negotiating the communication of the participants, how much they are willing to participate or not participate. If a provider is speaking at a rapid pace and the interpreter is keeping up with that pace, the elderly deaf patient may not be catching everything. Either the physician can't pick up on the cues that the deaf person isn't understanding, or they aren't checking in to make sure that they are understanding. Either way, this leaves the interpreter with generally two choices. Continue to let the appointment move as is, where the provider is speaking rapidly, or cue in the provider that you suspect the patient isn't able to keep up, and speaking more slowly would be helpful. Once this mismatch is identified, it is then up to the provider to take some kind of action or not. Brooks 2016 says, one interesting revelation was that patients sometimes indicate that they understand their provider even when they do not. Participants reported that their providers did not check in for understanding or did not recognize that communication was unsuccessful. Such gaps in understanding contribute to recurrent medical visits, poor treatment adherence, and additional cost to the patient and health system. There is a uniqueness interpreting for deaf seniors, and that requires interpersonal skills, knowing the needs of these deaf patients. And there are a few more themes underneath uniqueness that I found. Just going to let you read the quotes on this slide if you wish. You'll see a couple familiar themes here. Again, we have educating, interpreting skill, just the skill of the language and knowing how to put it into another language, and following up. I know these quotes are long. I realize I don't have a lot of time to continue with this presentation. So if you want to read those, you can go back and look at this presentation. So in the discussion, I love the use of the words fund of information. That concept really helps guide, I think, what medical interpreters do, and thinking about their clients and thinking, what is this person's fund of information or potential fund of information, and using that as a guideline to help move the conversation forward. And one of the participants knows Robin Dean, and he said, Robin Dean did a workshop and she talked about it, and she called it Fund of Information, or FOI. And when I get pieces of information that are not really for me to answer, or the deaf person expects me to answer, I think, what is their fund of information? Or what is the average hearing person's fund of information? And is that information that I can provide and fill in the gaps for the deaf individual within the idea of cultural mediation or a lack of access? Is that something that kind of everybody knows that I can fill in, or is that something that I need to interpret and allow the doctor to do? And there's a fine line sometimes, and it's sticky, but I find that happens more with the lack of access to basic information about their own health. And this really stuck with me when I interviewed this participant. I didn't think of it that way, And when you frame it that way and realize it could be cultural mediation, you're filling in knowledge in areas they don't have because they don't have the exposure as hearing individuals do. He went on to say, I would say my approach with all my clients are individualized, but it is to a much greater degree with my senior citizens. So, moving on. I wanted to put in these 2 extra slides after I met with Rachel. My discussions are a little bit long, so I wanted to kind of summarize everything in 2 slides, as a global view. And I thought a lot about what my interviewees said. And so if you'd like to read what I wrote on this slide, you may. Again, for the sake of time, I'm just gonna push forward. Many respondents mentioned these 5 themes in one way or another. Some stressed the importance of advocacy, while others seemed to care mostly about building rapport. At least 2 outright said that they are not subscribers of the CPC, but rather think of their job through the lens of concerned family member. One interpreter said, if this was my mother, what would I want for her? How would I want her to be treated by others, especially in this vulnerable situation? Ethically and morally, by simply being a good person, you are a good interpreter. Of course, there is a need for skilled medical interpreters, but suppose the only interpreter available does not have medical knowledge or experience interpreting concepts in healthcare. As long as that interpreter strives to follow the bullet points mentioned in the slide to your left and use the interpreting skills that they do have, they will be providing a good service. So, in conclusion, what can sign language interpreters do to help mitigate the barriers that deaf seniors encounter in medical settings? The broad answer to this question is a lot. They can do a lot. I was able to answer my research question partially, I think. I think also that there's a lot more here to uncover. The 5 main strategies that I noted before are all strategies that interpreters can utilize. Advocacy, partnership, and education seem to be the most prevalent. They're like the top 3 that were shared amongst all of my participants. And live medically trained ASL interpreters are preferred by consumers over ad hoc, VRI, written communication, lip reading, and even community interpreters. So, if I could critique my work, I would say most of the literature I reviewed discussed absence of interpreters, a lack of interpreters being available, or the infrequent use of interpreters to be the main barrier for which deaf people experience when trying to access healthcare. I was not interested in scenarios where interpreters weren't present. I want to know what barriers would present themselves and what interpreters could do, if anything, when the deaf person was faced with them. And that is kind of where I was going with my study. I feel like I'm still lacking an overview of how the field as a whole sees this issue. This is a qualitative study with narrow results. My sample was small, only 7 interpreters. All of them were certified and had been working in the medical field for at least 5 years. All of them worked in larger communities that had several hospitals and medical centers. These communities were also home to, from what I was told, a decent-sized deaf population. I would have liked to have more participants for my study. I also would have liked to find interpreters in smaller communities with less medical institutions. Including codas in my study would have also produced interesting results, I suspect. Lastly, I would have liked to have been able to host a focus group discussion rather than the one-on-one interviews. If I could have had all these elements in my study, I would have expected to see even more varying types of strategies used. I also think that the empathic attitudes and approaches that my participants expressed would have been just as prevalent throughout a larger group. I also suspect I would hear of more instances where interpreters, although knowing the tenets of the CPC, would share experiences where their behavior may have not aligned with those tenets, but their behavior was justified because it was for the benefit of the patient getting what they needed. One interpreter told me about a provider that made it his mission to take on deaf patients because he knew the access they were getting elsewhere was not to the standard it should be. Word got out that this doctor worked well with patients, always made sure to have interpreters, made sure to book long slots of time so that patients could have the time they needed with him. And he was learning how to communicate using sign language himself. He was also very open to interpreters' feedback and getting culturally educated. If I had more time, I would want to hear more about this provider specifically. Now, seeing the final product of this research, it is clear that I needed to find literature of cognitive decline of senior citizens and/or physical changes in senior citizens and how those features impact access to healthcare. Despite the points made in my critique, I believe that my work is relevant for all the following stakeholders. Number one, deaf seniors will benefit from my work as it starts to tease out what interpreters are doing to assist them in accessing healthcare. Number two, if more interpreters become aware of these strategies, the more likely it is that those interpreters working with deaf seniors can use those strategies in their own work. Perhaps for those that may have been hesitant before about, for example, advocating, will be comforted knowing that colleagues elsewhere are also advocating for their deaf senior consumers. I wonder if newer interpreters feel that they have to follow the CPC strictly. I wonder if novice interpreters feel that they are working in a healthcare setting and they feel they cannot step outside of those boundaries. Novice interpreters may be feeling they should or could do something to reduce the barriers deaf seniors encounter, but fear they are stepping outside of their professional role. Agencies will benefit from the results of this study as it shows there are professionals out there going above and beyond for not only their deaf consumers, but also the providers. If strategies like the ones highlighted in my slides become normalized, agencies can screen their independent contractors accordingly. Interpreter training programs will find that my results, if implemented in the classroom, can benefit students, especially those seeking to specialize in medical interpreting. And in terms of outlook, I'd like to go back to Holmes 2018 and this individual's idea to pursue further research where ASL interpreters' observations of communication with healthcare providers and deaf patients is studied. I find that intriguing. I would like to dial that concept in to see continued research in the following topic: medical interpreters' observations and experiences of communication between medical professionals and deaf senior citizens. I would be curious if a survey study or follow-up study would show results that support what I have found or not. It is my suspicion, due to some of the diverse opinions of some people in my research group, that there might be more to explore here. The results of my study suggest interpreters take on responsibility for advocating for their deaf consumers. Almost all of my participants mentioned that they do this in some way. It is possible that I had 7 amazing interpreters in my study, or advocating for deaf seniors is truly imperative to making interpreting for them in medical settings a success. A follow-up study based on this idea deserves deeper investigation to see more specifically how interpreters go about doing this. And lastly, I predict that interesting information could be obtained by hosting a focus group of deaf senior citizens and asking them about their experiences in healthcare. More specifically, what is it that they find challenging, and what acts or behaviors do they appreciate in their interpreters doing or not doing? This is a list of my references, and that is my research study in a nutshell. I hope you enjoyed watching this, and I really appreciate being a part of this program and this opportunity. Thank you so much.